focusing more towards neuromuscular conditions as well as movement disorder. So Jennifer, you're on. Please give your great talk to us. Thank you.
Awesome. Thank you so much, Dr. Ahmed. Thank you guys for letting me speak today. As I said, I'm going to be talking about genetic counseling in neurology. What are the benefits for patients, families, and their providers? And I kind of want to get into some of the technical aspects of what I do. So I don't have any disclosures to make. So I'm going to be talking today about who genetic counselors are, if some people are not familiar with what we do, what I do in patient sessions, and then some of the other aspects of my job, like variant interpretation, best practices, testing methodology, and psychosocial support. So starting off, what is genetic counseling? The National Society of Genetic Counselors defines it as the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So the type of things we do include interpretation of family and medical histories and risk assessment, education about inheritance, genetic testing, management, prevention, resources, and research to both patients and providers. And then we want to counsel to promote informed choices and adaptation to risks of conditions. And so who are genetic counselors? We're a specialized type of healthcare provider. So we do a master's degree in genetic counseling. As Dr. Ahmed said, I did my master's in medical science and human genetics and genetic counseling. So our training is a mix of clinical rotations like med school. We also do research. A lot of students publish their grad school research. And there's also a lot of didactic learning in classes in genetics and psychology. Most genetic counselors need to be board certified by the American Board of Genetic Counselors. So I recently got my certification. And then most counselors are also licensed in the state they work in. So I am licensed in Florida, but there are still a few states that don't offer licensure for genetic counseling. But essentially, we're experts in genetics and communication. We try to be patient advocates and educators. We can also work in a research capacity or as administration. And as of right now, the vast majority of genetic counselors provide direct patient care, so they are working clinically. 25% don't provide patient care, so these would be like counselors who work in a laboratory or in corporate, and then about 16% do a little bit of both. One huge distinction, we are not the same as geneticists. Geneticist refers to someone who has either a PhD or an MD in genetics, so there is a bit of a difference there. Looking into the history of the profession, so Sheldon Reed in 1947 was the first person to coin the term. He's considered the father of genetic counseling, and he really did a lot of work to distance genetics and medicine from eugenics. There definitely wasn't a good time for genetics in the 40s, but he really placed the emphasis on patient autonomy and informed decision making. The first genetic counseling program was at Sarah Lawrence in 1969, so really we're not that old of a profession. It's also notable, Sarah Lawrence used to be a women's college, and our profession is actually still about 95% female. So we are trying to diversify, but those are kind of, coming from our origins. And in 2019, there were 49 accredited programs in the US and Canada. It's really not a lot when you consider that the average class size is about 10 students. So that is a bit of a bottleneck for genetic counselors right now. There's not enough counselors to fill the need. And that's because there's just not enough counselors to mentor students. You have to do clinical rotations with a genetic counselor. So we are working on that. So as far as practice areas, it's a pretty wide scope. Most counselors who are clinical work in hospital and clinics, but you can see people in public health, universities, government, insurance companies, nonprofits. There are some private genetic counseling or genetic testing companies, pharmaceuticals, and then laboratory genetics. And as far as specialties, that also runs the gamut. The core, like the original specialties for genetic counseling were cancer, prenatal, and pediatrics. So, I think like 5 or 10 years ago, those were really the only options to go into. Our newer, gaining a lot of momentum specialties are cardiology and, of course, neurology, neurogenetics. So we're really excited about that. Definitely on the cutting edge, having a neurogenetic counselor here at Advent. But eventually we'd like to see genetic counselors in every specialty. They can be helpful in metabolic disease, even GI, or any specialty we'd eventually like to reach out to. So when we think about neurology genetic counseling, I like to kind of break up the disorders we see into these groups. So movement disorders, of course, being a big one. You'd see like spinocerebellar ataxia or SCA, Friedreich's ataxia, ATM, Huntington's, Parkinson's, sometimes mitochondrial ataxia, dystonia, and Tourette's. Neuromuscular is a lot of CMT, Charcot-Marie-Tooth, periodic paralysis, ALS, muscular dystrophies, and myotonic dystrophies, hereditary spastic paraplegia, SMA, and congenital myasthenic syndrome. And then in the other category, epilepsy is kind of on the rise too. Obviously, not all epilepsies have a genetic cause, but that can sometimes be helpful. There is a pretty low yield, though, for epilepsy genetic testing. We don't often get a diagnosis from doing testing. Dementia, which is a little bit controversial now. It's still kind of up in the air, like who's really qualifies to have genetic testing for dementia. Neurodevelopmental is great. Eventually, we like to see a lot of children for developmental delay or autism. And then on the horizon, where really there's no panels or testing available, but in the future, we want to move into headache and psychiatrics. Important to note, not all of these conditions have a genetic etiology, as I pointed out before. So for something, like Parkinson's disease, or ALS, only about 10% of patients diagnosed with ALS have a discoverable genetic change that is the cause of their ALS. So negative or inconclusive test results don't always rule out a diagnosis, and that's why clinical diagnosis is still so important. And I mean, a genetic component can help in diagnosis, but it's not always like the easy answer we're looking for. I want to talk a little bit about what I do with patients in appointments. So obviously aiding in diagnosis is a big one. So I do a chart review, and it's really great for me. The more detail is in their chart about their history and what they're being seen for. And then I would also come up with some direct patient questions depending on, what the suspected diagnosis is, or depending on their symptoms. A huge part of it is results disclosure. So you can see here, this is like an example of a genetic testing report that the patient would get and that I would go over with them. So you can see here, this was a pretty big panel of 143 genes, and they did get back a few variants of uncertain significance, which I'll talk about in a few minutes. But really, it's important to do like patient-friendly genetics review. So like, a patient, if they don't understand what a gene is or, what DNA is, it's going to be really hard for them to like actually grasp, have a solid understanding and make informed decisions about their genetic testing. So this is something I usually go over with them. I also try to make the genetics of their conditions, easier for them to understand. So this is actually a visual aid I made myself for a patient I saw with FSHD. So this condition is caused by actually a chromosome 4 contraction of the D4Z4 repeat array. So you can see here that little D4Z4 is represented by the yellow, and in a person who's affected, gets smaller, it contracts, they lose some of that DNA. And then you can see here, depending on how many repeats, how many DNA nucleotides are lost in that section, that would tell us what the disease is going to look like, full penetrance versus reduced. Same thing, myotonic dystrophy. This is another just visual aid I made to help a patient kind of visualize what the genetic etiology of their condition actually is. And of course, discussing uncertain results, which I'll talk about in a lot of detail. Family history is a big one too. So we always collect family history during a genetic counseling session. This is actually a cancer pedigree, but same thing. So we want to look at least 3 generations of a family, and we're asking questions specific to what the patient's being seen for, but also some more general questions just to make sure there's not something like completely out of left field that's going on in this family. I think I saw a patient for periodic paralysis, and then she ended up also being, at risk to be an SMA carrier. So things like that. And with these pedigrees, the circles are females, the squares are men. You can see here, like, these type of lines where they're connected under the line, these are siblings, and shapes connected directly by a line are partners. And of course, psychosocial usually comes up in these sessions as well, depending on what we're talking about. So I want to give you guys an example of risk assessment, how we would give the patient a specific number about their risk for a genetic condition. So this patient is BM. They're 65-year-old female, and they were being seen for progressive limb onset ALS. Their genetic testing came back. They did an ALS and hereditary dementia panel, completely negative. They also had a 123 gene comprehensive neuromuscular disorders panel, and they were found to be positive for a variant in COL6A2. So, that doesn't really have anything to do with their ALS diagnosis. It was kind of a secondary finding for this patient, but it was something that the patient was really interested in exploring and talking about. So because of this finding, we know that the patient is a carrier of an autosomal recessive COL6A2 related condition. We also call these, it's kind of a spectrum of conditions that we call collagen 6 related dystrophies. So the COL6A gene is associated with the spectrum of collagen 6, which includes dominant and recessive Bethlem myopathy and Ulrich congenital muscular dystrophy. And so the main characteristics of those are muscle weakness and joint contractures. So based on just this variant, you can see here, it's determined to be most likely inherited recessively just due to the variant interpretation. So this is a nonsense variant, meaning that the sequence change in the DNA creates a premature translation stop codon. So it's expected to completely disrupt protein function for that gene. And complete loss of function of homozygous variants in COL6A2 are associated with the more severe condition, which is Ulrich congenital myopathy. And the variant is also located in the TH domain on the same codon as a very well-known pathogenic variant in this disease. So we're very sure that this would be considered recessive condition. The patient was a little bit anxious about this result. So she wanted to know, she didn't have any children, but she wanted to know the reproductive risk for her niece. And apparently her sister had also tested positive for this exact same variant. So the exact prevalence of the collagen 6 related dystrophies is unknown, but they've made, a guess based on a few papers that have been published. In some populations, specifically, there were studies in Japan and Australia. It was actually noted to be the second most common congenital muscular dystrophy, but they estimate the prevalence of just Ulrich congenital muscular dystrophy to be 0.13 in 100,000, and it is a little bit higher for the less severe Bethlem. But so the patient wants to know, what is the risk for their niece? So you can see here, this is our patient, this is her sister. The black square indicates that they're both carriers. We don't know carrier status of patient's sister's daughter, her niece. So how are we going to determine that? So the risk for an autosomal recessive condition, if both parents are carriers, is 1/4 or 25%. But there is a half a chance that the patient's niece is a carrier, 50% chance that this patient will also inherit and carry this variant. So we know for her, the chance that she's a carrier is 50%. But what about the patient's partner? What is the risk that he also carries a mutation in this gene? So because we don't know, there's no carrier frequency known specifically for this gene, we can calculate it using the Hardy-Weinberg equation if we know the prevalence of the disease. So you can see here the Hardy-Weinberg basically describes dominant and recessive alleles here. So that's what the P and the Q are referring for. And essentially, it's just an equation to see how many completely unaffected, how many heterozygous, and how many homozygous recessive or affected people we expect to see in any population. And so all we have is the estimated prevalence of 0.13 in 100,000, but we'll go ahead and we can solve for the carrier frequency using 2PQ. And so when you do that, you get the carrier frequency is about 1 in 439. And so since there is a 50% chance for patient's niece to be affected, 1/439 chance that the partner is a carrier, and then times the 1/4 chance that if they're both carriers, the child would be affected. So the risk for the affected child is 1 in 3,512, or about 0.028%. So that definitely did make the patient feel a lot more reassured. I know it's kind of a lot of math for like when we already know it's a very, very low risk, but for this patient, it was something that she really wanted. This is also likely an overestimation because we don't know the exact carrier frequency, and the prevalence is going to include both recessive and dominant forms of Ullrich congenital muscular dystrophy. So it's probably in real life even lower than that. Another practical application for risk assessment is using the Bayes theorem of conditional probability to give an adjusted risk estimate for a child of a patient with Huntington's disease. So let's say I see a patient who is non-symptomatic, their parent is diagnosed with Huntington's disease. I can calculate the probability that the patient is a carrier, is going to have Huntington's disease, even though they're not symptomatic at age 55. So if we're going to assume the penetrance of Huntington's is 75% at age 55, so that means by age 55, 70% of patients who carry a mutation in the HTT gene have symptoms, then we can use these different, the Bayes kind of calculation to figure out the actual risk, including the age. So we're assuming we start off with a 50% chance that the patient is a carrier. Since we're saying they're 75% by age 55, the chance that they're a carrier and not affected would be 25 in 100, or 1 in 4. And we're assuming that if they're not a carrier, they're not going to be affected. And then, so a little bit of math here, but you get to the final answer being 1 in 5. So just from their age and knowing the penetrance at the age, we can say now your risk is gone from 50% to 1 in 5. So those are also kind of, good stats to be able to give the patient. So let's talk about variant interpretation, because this is a huge thing for genetics and neurology. I think this is the biggest issue facing neurogenetics. So there's never any black and white in genetics, and not all variants are pathogenic. But because neuro is a newer specialty, how do we classify these variants that we've never seen before in another patient and they've never been reported in the medical literature? It's also overall, just in general, a really good idea to recognize that the more genes you test, the more uncertainty you're going to get in return. So how does the lab even do variant interpretation? So when you order testing, you're going to get a lab report back, and all of the variants are either going to be labeled pathogenic, benign, or uncertain. So how does the lab make those classifications? The easy answer is it's based on their internal data and then international guidelines you can see in this ACMG standards paper. So there's different criteria for determining if a variant is benign or pathogenic, and they rate that criteria on its strength as evidence. So they give every type of evidence, either very strong, moderate, or supporting, and there's evidence separately for pathogenic versus benign. So, and each type of evidence is also assigned a number and a letter. So for example, PVS1 is a null variant, and that means that it's nonsense frame shift essentially, completely disrupts protein creation, and a gene where loss of function is the known mechanism of disease. So that's pretty strong evidence that this variant is probably pathogenic. And so essentially you go through, you look at all of these different categories, which I'll talk about in more detail, and then you add up the scores. Like if you have a certain number of very strong, or you have a certain number of very strong benign findings, the variant would be classified basically based on like an algorithm or like an equation. But sometimes labs still classify their variants differently. There's still like a lot that's open to interpretation, even though we're using these very rigid kind of rules. So it's really important as a clinical genetic counselor, you have to weigh in to determine specifically for your patient if there's a chance that this uncertain variant could actually be the cause of your patient's symptoms. So when I'm looking at variant interpretation, I get back for a patient an uncertain result that looks a little suspicious. This is kind of what I think about. So obviously, first I look at the lab's justification for their classification. Most labs will list out the reasons why they made that call, but they don't always give you the actual ACMG criteria with those little number letters. So I like to go and look on a website called Varzome. This is super helpful. It gives you the actual ACMG criteria. So PM2 is like a moderate evidence versus PP2 is supporting evidence. So like this variant, and it's actually a variant in a case I'll show you guys in just a little bit, but so it doesn't have a lot of strong evidence for pathogenicity, so it is uncertain. It's not good to base your entire interpretation off just this one site, but it is nice to see specifically which ACMG evidence they were using. And this website also kind of like bundles up a bunch of different things that are important for variant interpretation. It gathers a lot of information all in one place, which is super helpful. So another thing to look at is the variant present in the population database. So the most popular population database is NOMAD. And so essentially this is data we get from a bunch of healthy volunteers, so people who just volunteered their time to be a part of genetics research, and we're looking to see what does the allele count look like in the general healthy population. If we see a high number of this allele floating around in people who are healthy, it makes us a lot less suspicious for that specific variant to actually be pathogenic. This, though, is not a great criteria for everyone. So, our research is only good as the diversity we get in recruitment for research. So this is often really skewed for patients who are of minority descent. So if there's not a lot of people, of African or Asian descent who volunteer to be part of this, general population cohort, then it's not going to translate well to actually being able to base criteria off of this in variant interpretation. So for example, a patient who's African American could get a variant that's uncertain, and in reality, it's a very common variant that a lot of other people from that background carry, but we just don't know because not enough people were tested to be in this sample. Has the variant been reported in the literature in an affected individual, and how are other labs classifying this variant? So obviously, has the variant been reported in the literature is super important. That's going to be a huge thing we can base some of our decision making on. And then I put how are other labs classifying this variant, because you can find those both on this website called ClinVar. It's essentially just a database of variants that labs are, making public so that other providers can look and see. Like I said, not all labs interpret their variants the same way. So it's interesting when you see one lab that classified as uncertain versus one lab that classified as likely benign. So sometimes there is a little bit of difference there. And this website is also really great about listing all of the papers that mention that specific variant. I mean, you could definitely just go look on PubMed, but this is a lot easier. It saves a lot of time. Where is the variant located? That's another important thing. So is it located in a hotspot within the gene, at a splice site? What are the other variants that are really nearby? Are they also pathogenic? So sometimes it's helpful. The lab will definitely tell you this a lot of the time, but if not, it's helpful to look at the UCSC genome browser. I'll admit this is really better for CNVs or copy number variants, where it's a big deletion or duplication. You can see like specifically where in the gene this is. You can see here, it's literally just essentially like a map of the gene. This tiny little yellow line, that's our 1 point mutation that we've been looking at on all these other sites. So we can look around, and there's different kind of criteria you can add or take away from this chart. But so here it's showing us what the other variants look like that are near it. So there's a few pathogenic other variants that are somewhat close, but mostly a lot of uncertainty. And if you are also like looking at a greater space, like an actual CNV, you can turn on like the omen pathogenic gene. You can see like, are there any genes known to cause disease within this like deletion that the patient has. So this is kind of a cool tool, not as great for like most of the mutations we see in neurology though. And then obviously you want to check the literature and know the mechanism of pathogenicity for the gene you're looking at. Like if it's loss of function, but you know that this variant is going to cause gain of function, we're not as concerned unless, we find evidence otherwise. But yeah, essentially just compare the type of variant to the expected protein outcome. There are a few algorithms that will try to predict pathogenicity scores. So like it's an algorithm, you put in the DNA change and it tries to predict like what the change in the amino acids is going to be, and then like interpret that into a protein. And obviously this is like really difficult because proteins are complicated. It has to do with like splicing and different transcripts and then like the conformation of the protein folding. So these are really not like a great way to classify your variants, but a lot of labs do throw this in as like some additional evidence. But you can see here for the same variant we've been looking at this whole time, 11 of these algorithms said that it was going to be pathogenic and 13 said that it's benign. So it's like a toss-up, not super helpful. But really, like when we're looking at a patient in clinic, we want to look at the other variant interpretation considerations. And the huge one is patient phenotype. Like this is hugely important. So the more detailed notes and the more questions I'm able to ask the patient and look at their medical history, the better. The thing about genetic testing, especially with something like neurology, where you're going to get so many uses no matter what, if you test anyone with one of these panels, like a random person who has absolutely no neuropathy, and you give them the neuropathy panel, they're going to come back with variants of uncertain significance. So what's important here is, does the patient actually have a phenotype that matches this gene, right? And that's also what the lab is doing. So it's also really important when we're ordering these tests that we make sure we're giving a really detailed story of what the patient's symptoms actually look like, because that's how they sift through all of these genes and all of these variants and try to decide what could actually, be harmful to the patient. Phenotype is really like the first thing you're looking at. We also want to look at family history. That's important. Obviously, we can see sometimes a pattern in the family that can lead us in one direction. And also variant segregation in the family. We do a segregation study that's really helpful. So sometimes if it's a very suspicious variant of uncertain significant or VUS, the lab will offer for free to test other affected family members. And if a bunch of family members have the same condition and they also carry this variant, that makes it a lot less likely that that is a pathogenic variant, even though the lab is still classifying it as uncertain. So here's a case example of variant interpretation and how this can be really important in clinic. And this is actually a case I saw in Children's Healthcare of Atlanta at the pediatric neurology clinical rotation, but I was asked to consult with neurology on this case. So the patient's a 37-year-old pregnant female. She went ahead and did a 48 gene pan-ethnic carrier screening, and that showed a pathogenic DMD variant. So she went ahead and did the amnio at 16 weeks, and they discovered that it was a male fetus who also tested positive for that same variant. So DMD causes a spectrum of X-linked muscle disease. So most well known is Duchenne and Becker muscular dystrophy, but also there is DMD-related cardiomyopathy. And the clinical findings that would make us suspicious of a patient with one of these muscular dystrophies would be like elevated CK or a hemizygous pathogenic variant. You can also do a muscle biopsy if needed, but obviously we can't do those things on a fetus. So there is a distinction between Duchenne muscular dystrophy and Becker muscular dystrophy. Clinically, it's based on the age in which the child needs wheelchair use. But so both Becker and Duchenne are progressive muscle diseases involving primarily skeletal muscles, and they're both X-linked, so usually passed from a mother to a son. Duchenne or DMD is more severe. It usually presents earlier in childhood, and you'd see delayed motor milestones, waddling gait, difficulty climbing the stairs, and a much more rapid progression. And those children are usually in a wheelchair by around age 12, and cardiomyopathy is expected by age 18, as well as respiratory complications. And Becker is a lot milder. So in some cases, patients may not even experience symptoms until like age 30 or be able to walk until age 60. So there is like a very wide range of phenotype just with this one gene. But heart failure is still a common cause of death for these patients. So really, this gene causes this huge spectrum of conditions. And how do we know what this baby is going to look like when they're born? How do we know what their phenotype is going to look like? So the big question here was, do we expect Duchenne or Becker muscular dystrophy? The mom was pretty anxious. She really wanted to know what she could expect for her son. So on the right up here, you can see the specific variant this patient had. It is a little bit unusual because it's a point mutation. So actually for DMD, the vast majority of these pathogenic mutations are deletions. So about 65 to 80% are deletions, and then only 20 to 35% are sequence variants like this one. And so like this is, it's very difficult to determine the phenotype just based on a variant alone, especially for DMD. So there are some rules that can kind of help us parse out genotype-phenotype correlation. So there's the reading frame rule, meaning pathogenic variants that are in frame are usually milder Becker muscular dystrophy, whereas the out of frame deletions or mutations are typically Duchenne muscular dystrophy. And that's because the in frame still allows some of the dystrophin protein to be produced. Essentially, lack of dystrophin protein is essentially what causes this condition. But in Duchenne muscular dystrophy, the mutation causes such an issue with the gene that there's very little or absent dystrophin production. So one of the main rules is the reading frame rule. And so this has about 91 to 92% accuracy, like I was just discussing. There's 10% exceptions. It's also really important for the patient, not just for the patient to like have a prediction, but also to develop exon skipping therapies. So this kind of has like a wider implication other than just in like clinical utility. And so this specific variant is an exon 28, and it's a nonsense variant. It has a premature translational stop codon, and we would expect, based on how much damage that would do, there to be absent or disrupted protein product. So just looking off the bat, we would expect a Duchenne phenotype for this patient. But it's reported in the literature in a few individuals with Becker muscular dystrophy. So why is that? So there's this great paper by Matteo et al. In 2013. They analyzed 98 point mutations in DMD, and the majority of truncating mutations were associated with severe phenotypes. So like ours, the truncating variant. But 11% of patients with Becker or just X-linked cardiomyopathy, a much less severe phenotype, presented with nonsense or frame shift mutations. So this study found 6 mutations in 5 frame skippable exons, one of those exons being 28, where our variant is in this patient. So essentially, frame skippable means that the DNA can continue on, it can skip over the problem area and keep on producing transcripts to be made into protein. So in this paper actually had a patient with the exact same mutation, and they found about 4% of transcripts coming from that DNA were skipping exon 28, and 35% were skipping both 28 and 29. So that's about 39% of the transcripts made from that gene that are still able to produce dystrophin. And you can see here, this is a picture from that paper of the dystrophin staining. So you can see on top, this is what it's supposed to look like in a healthy individual. The second individual had actual Duchenne muscular dystrophy. You can see how depleted that dystrophin is. And then the last patient is a picture of a patient with the exact same mutation as our patient. And you can see there is still more dystrophin that can be seen. And this finding is actually further corroborated by another paper in 2020 by Torella. And so they actually made a lot of really great moves in genotype-phenotype correlation for DMD based on the exon that the variant is located in. And I won't go too much into that, so we have time. And then this is another case example of variant interpretation, but for this one, really segregation is what's important here. So we had a patient, GW, who's a 69-year-old male, and he had a history of neuropathy, hearing loss, and tremor. His EMG showed slow nerve conduction velocities that were indicative of a myelinating neuropathy. And so he did his testing. As you can see at the top here, this is his test report. He did have one pathogenic variant that came back and just made him a carrier for an autosomal recessive condition. We're not really concerned about that. Doesn't explain patient's symptoms. But there was one more suspicious variant in a gene called DDAP1, and that's associated with autosomal dominant and recessive forms of CMT, Charcot-Marie tooth. So they're kind of classified under GDAP1 related hereditary motor and sensory neuropathies. This GDAP1 is associated with both demyelinating and axonal. We typically tend to see age of onset ranging from infancy to early childhood, and with disabilities becoming apparent pretty early in life, and that really wasn't the case for our patient. The lower extremities are affected earlier and more severely than the upper extremities. And autosomal recessive inheritance is the most common inheritance pattern for this gene. But there has been some autosomal dominant inheritance that's also been observed. So autosomal dominant GDAP1 CMT is typically more mild than the recessive form, and you would expect onset later in life, in adulthood, with a slower disease progression. So that does sound a little bit more like the phenotype our patient's presenting. So we ended up being able to do a family segregation study because the lab offered free testing to 2 of the patient's family members. And if you can see here in the pedigree, the patient has a mother and a few siblings who also have neuropathy, very similar symptoms. And so they did the testing and found that both the patient's mother and his brother also carry the same variant. So that makes us very suspicious that this could actually be a variant that is causing patients' underlying symptoms. But before we can really, roll with that, we have to also make sure that there is some kind of explanation mechanistically to explain why this variant or this gene could be causing autosomal dominant disease. So GDAP1 is actually very important for the mitochondrial outer membrane protein. And so it's important for mitochondrial dynamics and functioning, which is obviously important for neurons and muscle cells. But the overexpression of GDAP1 induces mitochondrial fission. And that's what is expected to cause the phenotype for recessive variants. But they recently found that dominant mutations in GDAP1 alter the mitochondrial fusion, so rather than fission, fusion process. And so there's a clear difference between mitochondrial dynamics between the dominant and recessive mutations, but essentially you need a balance of fission and fusion. So any kind of change with this is, harmful to the cells. Another thing that is really important for genetic counselors, best practice and ethics. So this is another big role that genetic counselors can play in clinic. So, we really want to focus on consenting for genetic testing. So you want patients to know about their privacy and their rights. So that kind of falls under GINA, the Genetic Information Non-Disclosure Act. So GINA protects patients from discrimination by their health insurance companies and by their employers, if the employer has more than 15 employees. And so those 2 entities cannot ask a patient for their genetic testing results, and they cannot make decisions based on those genetic testing results. What it doesn't apply to, though, is long-term care insurance and life insurance. So if there's, a pretty high risk that the patient's going to come back with a familial variant, good idea for them to have their life insurance set, usually. We also want to walk the patient through the limitations and benefits of research, like what can this testing actually tell us versus what it can. I know for a lot of CMT patients, they have a very clear family history, very clear clinical symptoms of CMT, but we just don't find a genetic cause, and that is the reality sometimes. We can also help consent patients for research or explaining to patients how their data might be used in research by certain labs. A lot of times labs that offer free testing are using that patient data for research, so it's important patients know that. A huge one is incidental findings. So this is any other actionable variants. So variants in genes that are not specifically related to what we were testing the patient for. You know, if you did like an exome and you were looking for like, let's say epilepsy genes, and it comes back and this patient has a BRCA pathogenic mutation, that is a gene that has a very high risk for hereditary breast and ovarian cancer. So now this patient has to deal with the implications of that when it wasn't what we were looking for. I mean, arguably it is nice that the patient now knows and they can get the proper preventative care. But it can take a toll on the patient's mental health. We could also find carrier status or certain types of tests. If we're doing a trio, we could find non-paternity or consanguinity if we're ordering a SNP array. So these are kind of things we need to be on top of and make sure patients are aware of. We also want to maintain patient autonomy. That is the most important thing. We use non-directiveness. Patients ultimately use the information we give them to make their own decisions on whether or not testing is right for them. It's also important for practice guidelines and position statements. So things like testing of minors. So it's pretty well in agreement among the genetics community that we don't test minors for adult onset conditions because it medicalizes them earlier than necessary and they're really not old enough to decide whether or not they want that information. So we want to protect their autonomy. Unless, of course, the child is having symptoms, and of course, we can do genetic testing. Whole genome sequencing, is that something that we really want to be ordering on a regular basis? Although it does have some benefits like pretty clean coverage, there's a lot of incidental findings and uncertain findings. ApoE testing. So ApoE is a gene that's associated with Alzheimer's disease, but it's really not predictive of Alzheimer's disease. So people are like getting this testing done in 23andMe and other direct-to-consumer places. Like, should that be the case? Should we offer this? Absolutely not. But that's something that people are interested in. And then predictive testing for Huntington's, which I'll go over in just a moment. So this is just an example of the ACMG recommendations for secondary findings. So when you order an exome, you have to let the patient know there's this list of 73 genes that have actionable clinical follow-up with them. Like we talked about the BRCA gene, there's preventative treatment for that. So they include these 73 genes, it used to be only 56, that they will report back if they find a pathogenic variant, even if it's not what the patient is being tested for. Sometimes you can opt out of the secondary findings, but some labs don't let you opt out. So that's a really important point to be thinking about before ordering an exome or like some really comprehensive testing. We don't really have to worry about it as much when we're ordering a panel. And then the recommendations for predictive genetic testing in Huntington's disease. So this is really important. We're starting up our Huntington's clinic and we want to make sure we're taking care of these pre-symptomatic at-risk individuals. And there are very specific guidelines. So we want this to take place in a supportive environment. An individual shouldn't be stressed or pressed for time or concerned about costs. All active psychiatric problems need to be stabilized before testing. So that's why it's so important for people to see a psychiatrist before they see me. There is an increased risk for suicide in patients who test positive. It's good for them to have a neurological evaluation, even though they're technically asymptomatic. Sometimes they're just concerned about possible symptoms, and a normal exam can be sufficiently reassuring for these patients. But even if not, you still want to establish a baseline for these patients so you can kind of track disease progress. And then with the genetic counselor, it's really recommended they do at least 2 in-person visits and a telephone contracting before the patient even sets foot in the office. At visit 1, ideally, they do the informed consent and have mental health screening, a neurological exam, and a blood draw or sample taken. And then at visit 2, we would do the disclosure of results in person. And we would arrange a specific time and day so that the patient, is not expecting to get a call. They know what day they're getting this news. And we would also pre-arrange a follow-up a few weeks later after the results disclosure to check up on the patient and see how they're doing. Another important part of my job is testing methodology. So a lot of times we're doing panels for neurology. So panels is when we test a ton of different genes all at once that have similar conditions associated with them. Since NGS or next generation sequencing came out in 2015, we've been able to do this really quickly and really cheaply. So genetic test prices have dropped so dramatically, even just in the last 5 to 10 years. But there's things you want to, all panels are not created equally. You want to make sure that the panel you're ordering has the right genes on it, genes that you actually would want to test the patient for. You can actually also look at the quality metrics. So like the depth of the reads, you want at least a 20 read depth. And I'll explain a little bit what that means on the next slide. And in the places where there's not good coverage in certain genes, they do Sanger, which is the gold standard testing, in places with low coverage? Like, are we going to be missing any variants if we order this test? It's also repeat expansion testing is kind of its own thing because really usually they don't include them on sequencing panels. So that's why, for example, C9orf72 is the most common, or it's thought to be the most common ALS gene that was not previously on the ALS panel because of the methodology. You have to use either repeat primed PCR or MLPA to find these repeat expansions, and you can't do that on just a regular NGS sequencing panel. So they just now added it on, which is a huge success, like a huge victory. It's going to be super helpful for patients. And then the other big neurology repeat expansion conditions are like myotonic dystrophy, Huntington's, and spinocerebellar ataxia. A chromosomal microarray is looking at copy number variants, or essentially big regions of deletions or duplications of the DNA. This is kind of the first line test for developmental disabilities and autism in young children, but there's obviously other uses as well. A lot of cytochrome conditions or deletion syndromes. Whole genome sequencing, we kind of talked about. There's whole exome and whole genome. Essentially, just the difference there, you're still sequencing every gene. The whole exome only includes the protein coding regions, whereas the genome literally sequences the entire genome. A karyotype really isn't used a lot anymore, even I guess really in prenatal only, but you'd visualize all the chromosomes. This is used to diagnose huge deletions or missing pieces of a chromosome or extra chromosomes. And then mitochondrial DNA actually comes up quite a bit in neurology. So it's important to order a panel that includes both nuclear DNA and also the mitochondrial DNA because it does have its own DNA as an organelle. And then you can see here, we get these reports back, and when it gives us a variant, there's a few things we look at. Mostly this part is what's important. This gives us the transcript version, which is just only important if you're looking it up on one of these databases. But so this essentially tells us right here what position, which number nucleotide this variant is at. And then in this example, it's a change where there's supposed to be a G, there was actually an A. And then the last part of it actually tells us what changes about the protein. What is the difference in amino acids? So you can see there, and the position in the protein that this change takes place. And then, next generation sequencing is been a really great, and this is what most of our testing is done. So essentially the DNA is sequenced in very short pieces. And although the pieces are very short, you're doing this in mass, a ton all at once. So essentially the gray balls are nucleotide in the DNA that are stuck onto something. And then every time you find a nucleotide, or the nucleotides in this solution are kind of floating around and sticks to its complementary reference, it gives off a spark of light. And so you do this a bunch of times repeatedly, and the computer is able to sequence that based on these sparks of light. And that's what we kind of say when we're thinking about read depth, because the higher the read depth, the less chance there is that there is a mistake in the reading. And then last but not least, psychosocial support can be really important in these sessions. especially if it's a positive results disclosure. Like Huntington's is a huge one. We get specialized training in how to give bad news, how to give a life-altering diagnosis, which is a lot of times what these patients are getting in neurology. Also, we kind of help discussions with family members. Some patients don't want to talk to their family members who are at high risk, so we can kind of coach them and help them. Make sure the whole family is aware of their risk. Retrieving sensitive information is part of our training, and of course, responding to grief. And that is about what I have for everyone. Please let me know if there's any questions. Here are my references, and then the final slide. Thank you so much.
Thank you, Jennifer. Great talk. Learned a lot today. I will say, it's a very complex topic, and we are learning a lot of new information. So is there any question from the audience?
Yeah, I have a quick comment and question. Actually, very useful, and maybe we need more of this actually to get a better